Ready
I
for
think
upload?
we have some people joining us. We have people here in the forum. I have a couple announcements before I get to our speaker for today. So first off, Holocaust Remembrance Week is coming up. So the program for Holocaust, Genocide, and Contemporary Bioethics is having several events the week of April 21st. So keep your eyes out for that programming. There should be flyers around campus for that. And then I also wanted to highlight the center's Portrait of an Unquiet Mind, which is a presentation and concert on Monday, May 5th at 7 p.m. With a group of individuals who have bipolar disorder and are also musicians. So free and open to the public, and that'll be a really exciting event. Thanks. Anything else, Malia, that I'm missing? I think that's great. Okay. So I'm very excited today to introduce Abraham Nussbaum, who's our guest. Abraham Nussbaum is a physician and a writer. At Denver Health, he's the Chief Education Officer, and at the University of Colorado School of Medicine, he's a Professor of Psychiatry and the Assistant Dean of Graduate Medical Education. He has authored 6 books, most recently this one, which we'll be talking about today, Progress Notes, 1 Year in the Future of Medicine, which follows 7 medical students during their clinical training, and it's kind of an innovative new clinical training pathway. So we'll talk about that. His work has been published in America, Commonweal, Psych News, Plough, Stat, The Wall Street Journal, The Washington Post, and Times Higher Education. And this book, as well as his previous book, The Finest Traditions of My Calling, which we may also touch on, are available wherever you get your books. And I also have the pleasure of calling Abraham a really close friend and mentor as well. And so I'm really excited to chat with you.
Grateful to be here. It does feel like a late night talk show, kind of up all night with Dr. Kissler.
That's
So,
right. Yeah, it's a little bright outside, but we do have a studio audience.
We do.
Maybe we'll get a laugh track.
Maybe we'll get a band at some point. Catherine Ryan will play drums or something. I don't know. I don't know what instrument you want to play, but pick one.
That sounds
Thanks
great.
for
That
having me,
sounds
Mark.
great.
I'm grateful to be here.
So I'm excited to talk about a couple of things because I want to talk about the book and the ideas that you have around medical formation, changes in medical education, and I also want to talk about the process of writing a book and the reasons for writing a book. So I thought maybe we'd start there. Why, out of all the things that you could have done, blog posts, podcasts, other things, why do you think a book was the right format for this?
Yeah, great question. Because if you want to tell a story, history says that a book's one of the best ways to do so. It's a technology that endures, right? One of the things when you have a book is that you have to have characters, action, and plot. Most things that you talked about there, blogs, social media posts, Substack posts, tweets, those sorts of things, they're ephemeral. I mean, by design, they're designed to engage an emotional response rather than to have a story that lives over time.
So you wanted to tell a story.
I did.
And tell us a little bit about the story that you wanted to tell. Why'd you write this particular book?
Yeah, great question. I think if you ask the average American, they'll broadly tell you that American healthcare is broken. They'll say it's too costly, too complex, too difficult to access. As somebody who went through that training and found it odd and also life-giving, and both of those things are true for me, I have come to believe that the way we train people is the fundamental flaw in the American healthcare system. It sets up all the other things that we do. And so I wanted to tell a story, and I believe that we're living through a moment where people are asking existential questions about why someone should train as a healthcare worker and how they should spend their time, who should train as a healthcare worker and why and where. And I think those things will portend significant changes for the next century. And I wanted to tell a story about that.
Great. I'm curious to talk a little bit more about some of the specific things that you were seeing before this LIC curriculum was introduced. What are some of the failings that you think that in medical education that have spread into the system as a whole?
Yeah, so if you think about the way that we've traditionally trained people, at least for the last 100 years, we say traditionally, but it's just 100 years. That's a very short timeline. It's very American to say traditional is 100 years. It's something like the Flexner-Oslerian compromise, where we say a young person who can afford to go to a university, often an elite university, should have significant scientific training. And that's their core criteria for admission. And then based on that, they would go to a 4-year medical school, ideally tied to a research university. Traditionally, those first 2 years are spent in a lecture hall or a laboratory, and your first patient that you really engage with is a cadaver. And that's intentionally. If you go back and look at the Flexner report, Flexner says the cadaver lab is where the whys are brought to book. And that's the idea that the most important thing is to learn from the dead body first. And that it's only after that that you go out and learn in the community. And when you do so, you learn in a medicalized setting, mostly a hospital, where young people who are learning to be physicians follow the physicians and apprentice to them rather than following patients. And that's what I mean by it being this kind of fundamental flaw in the way we train physicians. That we ought to say physicians are the servants of the sick, and so they ought to follow the sick. And instead we say that they're being formed to the needs of the profession. That's a very particular way of training physicians. It's very American, it's very 20th century, and it has tremendous benefits, but it also has some drawbacks.
Could you describe what the LIC program is for those who might not be familiar with it?
Yeah, so I've answered your question one way. I'll answer them a little bit differently. Why did I write this book? In part because a terrific physician, now at the university, named Dr. Jennifer Adams, convinced me to. And I was at a place at Denver Health, you mentioned that I'm the chief education officer, where I was doing an audit of all of our different health programs. They weren't particularly well organized. We were largely welcoming learners based on the question of who wanted to be there. And I started keeping open office hours in the Good Day Cafe in the basement of Denver Health, and Dr. Adams came and talked about her medical students to me. And I didn't really know her, and I didn't really know what she was talking about. And she started to send me LIC med students, and I didn't like it because it wasn't the way I was trained. I was used to having students for a period of time, usually a month, and they would come for this immersion period. I should back up. I'm an inpatient psychiatrist. My clinical home is the inpatient unit at Denver Health, where I'm privileged to see people who are experiencing a psychotic disorder, a suicidal event, right? I get to see people during a really difficult moment of their life. It's a team-based system. Usually the med students were there for a month. And she started sending me students who were there just there for a week and would leave during the day to go follow patients that they had other relationships with. It confused me because it wasn't the way I was trained. It wasn't the way I was used to med students going. But she convinced me over time. She now runs LICs across the state with a large team of awesome people, many of them on this call, I'm sure, and know about that. But it was really her passion for that work that inspired me to write the book. Fundamentally, the LIC is a longitudinal integrated curriculum. And the idea is that people spend time at a specific clinical site with a cohort of patients that they follow wherever they go for clinical care, and ideally also in their community setting. There's lots of variations. It's occurred around the world. It's been going on for decades, but it's only in the last 20 years that it's come to prominence in medical education. This is a weird late night talk show when you're talking med ed, but thanks for having me.
It's a good one. So rather than having kind of a rarefied, highly concentrated scientific and institutional grounding of the education, you're saying that this gets kind of broken up into a different, out into the community in a little bit of a different way.
Yeah, I want to be clear. It's not that Dr. Adams or anybody involved in the LIC is opposed to a rigorous scientific education, nor am I, right? It's the idea of saying, where's your alliance? How do you go and get that learning, right? I'm team science all the way down. I'm also just team community at the same time. And I don't think those two things have to be in opposition. The question is how you structure your days and times. And fundamentally, I think we talk about a little bit what's wrong with healthcare, but you think about medical education, medical practice. The question is how you structure somebody's days so they can live better and see their patients better.
One of the guiding images that you come back to in the book is this concept of two textbooks.
Yeah.
You say that we traditionally have been learning from one textbook and that these students that you followed start to learn from two different textbooks. What do you mean by that?
Yeah, great question. So I told you that when I went to med school, when I went to med school, the same time my sister went to nursing school. And she said the first day of nursing school, I met a patient and I learned how to care for them and turn them in a bed and make a bed for them. And my first patient was a cadaver, right? And I learned to cut down their spine and remove their skin. And I spent 4 hours a day, 3 days a week for 9 months. I didn't meet a human patient, a living patient for, I think, the better part of a year during an assignment from the school. Great school, I loved my training. I didn't know why that was. And I didn't know why I was really being trained to think about just the body abstracted from a community or a place. In time, I read the Flexner Report, which if you haven't read the Flexner Report, it's an interesting read. You can find a PDF of it online. It's the crystallization of a whole movement from the progressive era of reforming medical education by tying it to the research university. And if you read the section about Colorado, each place that Flexner visits, he talks about visiting a place for sometimes as little as 3 hours. And the way he rates those schools is on the quality of their cadavers. And he says that's really what matters, is do they have a lab? Do they have good cadavers? That's the question. The other thing he'll sometimes ask about is books. And that got me thinking about it. And then that line that he has that the wise are brought to book in the cadaver lab. And I thought about that in my own training and in the flexnerian model, the body itself, the mute, stilled body, is the textbook physicians and other healthcare workers are supposed to learn on. If you read the Flexner report, it talks specifically about the University of Colorado and Denver Health. And it says in particular that Denver Health was previously in a relationship with a different med school. There were 5 med schools in Colorado. This says that the relationship with Denver Health should be moved to the University of Colorado, and it says it's in the general interest of the community. But nowhere in the Flexner report does he define what a community is, what its interest is, or how he assesses it. And I just don't believe that in 1907 or today, that if you asked a general community member, what does it mean to have a good med school? They would say, it's about the quality of the cadaver lab. It's really important that physicians learn how to perform dissections. Again, I'm team science. But it's really also clear that the Flexner model didn't ask what the general interest of the community was. So people have had all sorts of criticisms of the Flexner report. Famously, after the Flexner report, it lays out a set of concerns and qualifications for a med school that really only well-funded research universities could have, and many of them receive philanthropic funding, and it really closes the door of medicine to people who don't meet its quote-unquote criteria. So medicine really becomes training for mostly able-bodied white Protestant men. The number of Black men in medicine was higher in the late 19th century than it is even today on a per capita basis in the United States. The number of women in medicine was higher in the late 19th century until the 1990s on a per capita basis. So clearly Flexner didn't define the general interest of the community in a way that we would want to today. And so I believe that what it means to be well-trained is that you should know the heck out of the body. You should know the sciences. You should learn the textbook of the body. But it's not that the textbook community is opposed to that. It's that it deepens that knowledge of that to say, what does it mean to have a body, to live in the world, to be embodied, to live in a community? I think physicians and other healthcare workers should know both.
Do you think this kind of training model produces different physicians who are able to inhabit both of those
Yeah,
worlds?
I mean, that's what Dr. Adams convinced me of, and that's what she convinced the school of, right? That's why the University of Colorado has gone to this curriculum change, is that she convinced people it did, and she has some data to show that it does. Other people nationwide have as well, and Dr. Adams has been leading the way in that. You know, the idea is that it shows people who are more community-minded, more reflective, less burnout, you know, better able to think about these things long-term.
Great. Another image or another guiding image that you talk about is physician as a hero and kind of this heroic narrative that medicine often tells about itself, and an alternative to that. So I'm curious if you'd tell us a little bit about that.
Yeah, so sometimes when I give talks about this, I try to be a little provocative, and I tell people that I want physicians to be vampires. And I say that because oftentimes physicians and other healthcare workers are encouraged to be heroes. I love the place I practice, but it's a place that I'm critical of because it, just like any place, deserves it. I was walking at Denver Health this morning, and stenciled on the sidewalk, there's a little message to you as you sit at the crosswalk, and it says, "You're a hero." And I think about where that comes from. We think about in the pandemic, we saw pictures of nurses and doctors, you know, wearing wings, right? And they were like in gloves, boxing gloves. I sometimes show these pictures. You think about where those images come from. It really comes from the Flexner report and the physician that Flexner lionized and held up as the model for medical education. And that's Sir William Osler. For every physician in this room or anybody who goes to a physician, Osler is the person most responsible for structuring the rhythms of our day. The irony is that Osler said that medicine should be tied to the research university, but really made no research breakthroughs of his own. There's a couple of physical exam findings, famously Osler's nodes, but he himself was not a researcher. What Osler did is created the structure for our day. He designed the idea of the pre-medical curriculum, medical education, bedside teaching, and the idea of a residency. More importantly, Osler gave us the language to describe what a physician does. He wrote a series of essays, which were collected in a book called Equanimitas. For 2 generations, a pharmaceutical company gave every graduating physician in the United States a copy of Equanimitas. And if you go back and read like New England Journal of Medicine op-eds, they're always quoting Osler. An internal medicine grand rounds has to quote Osler. At my med school, the cafe was called the Osler Cafe. In the basement of Denver Health, there's an Osler conference room. He never visited either one of those places. But his ideas and his language carried. And the language that Osler used was this very kind of 19th century Protestant language. Osler was raised by a minister, so it's very much flavored by the King James Bible. He himself was no longer a believer, but you can say that he transferred his faith from the Protestant church really to the house of medicine. So he describes medicine as a noble calling for which you should set aside all of their goods in your life. He says, you shouldn't have a child, you shouldn't get married, and it's very gendered because those things will distract you from the life in the hospital. He says, you should think of your work as noble and heroic. You know you're going to risk things and it's going to come at personal cost. That's that language of nobility, and you see it in some of the copies of Equanimitas. They print it, and the cover is this kind of heraldic image with a knight armor, which is weird because I don't want to wear a knight's armor as a doctor. Doctors don't need knight's armor. But the title itself, Equanimitas, refers to the emotional state that a physician's supposed to have, which is to see remarkable, difficult things and admit no emotional consequence of it, right? As a psychiatrist, that worries me. As a person, that worries me, right? But it was what we told 100 years of people to do, is to think about that language of being a noble hero who doesn't suffer emotional change, doesn't relate to their patients. So, Mark asked me this question of what do I think you should be instead of a noble hero? I think you should be a humble vampire. And the reason why I say that is there's this book I read a couple years ago called Transformative Experiences. It's a small studio audience, but anybody read Transformative Experiences? I wrote about it, this book 6 years ago, but as it happens, there was recently in the last year, there was a piece about this in the New Yorker, which provides a great introduction to it if you want. But briefly, there's a philosopher named L.A. Paul, and she wrote this book called Transformative Experiences. And in the book, she says most things in life are a choice, right? And you can use rational decision-making to make the choice. Do I want coffee or tea? Do I want to go to the bathroom now or later? Do I want to come to this awesome medical humanities lecture, or would I rather go outside? Oh, wait, the weather's bad. I'll go inside to the medical humanities lecture today. But Paul says there are things that you'll face a choice, and you know on the other side of the choice, you'll be a very different person, and you can't go back. He says, how do you make that choice? And she says, imagine that you're born deaf and you get a cochlear implant. And you know that a cochlear implant and hearing the world will change how you relate to other people, to yourself, and will rewire your brain. How do you choose that? And she says, imagine that you choose to become a parent for the first time. You can't give the baby back. I know you can in some small segments, but largely it changes you. Most people who've had a child know this. She says, choosing to marry. And she names one profession. Oh, and vampires. And she says, imagine that you have this choice. Your friends say you can die or you can be a vampire and be the undead, right? And she says, the thing about being a vampire is you don't know what it's going to be like, right? And you can't go back. Nobody's like a vampire and then comes back. So she uses this image. She picks only one job as being like that. And she picks being a physician. Because she says it will change the way you relate in the world, to yourself and to other people. It requires a large set of sacrifices, right? And if you think about it, you can see this in the way that we are things like a mandated reporter. If you and I see somebody abusing a child, even if we're in the King Supers, right? We can't just walk by. We have a responsibility to do these things, right? If you think about this question about how you see people after medical training, my guess is it's pretty different than you do before medical training. I relate to people differently in the world. Some of what Osler's talking about with equanimity is right. When I see a person who's after a suicide attempt or is psychotic, it's good that I don't become so awash in my own emotions that I can't help them, right? But there's a different way to explain that than nobility and heroic. And I think L.A. Paul provides that with this language of being a vampire. Because then you help to think about this is more like becoming a parent, where it changes how you are in the world. It's not shift work. It's not something you do for a time. It's a different way of being in the world. And that's fundamentally what I mean when I say that a physician's a vampire, is that it's like being a parent. It's a different way of being in the world, and you have to make that choice. But it's not heroic, and it's not noble.
So there's a couple points there that I want to return to. Thank you. I remember in medical training these boundary experiences, or feeling like, we're stepping across a threshold here, not exactly sure what's on the other side. And often these first initial patient encounters were really that way. And seeing distress, seeing suffering, seeing the broken bodies in the hospital, out of the hospital, each of those became a boundary experience of sorts that I imagine has turned us all, into different people, different ways of engaging with those.
Yeah, so in the book, I try to illustrate the difference between these two, of saying, like, when I was on trauma surgery as a med student, amazing thing, surgeons are amazing, trauma surgeons are amazing people. My job in that was also often to get a set of procedures, and everybody in the room was often there to get a procedure. So there were people at all different levels of training, right? The anesthesiologist wanted to get the tube, right? The fellows wanted to do a certain thing. And at my med school, the job of a medical student was often to assess for rectal tone and a rectal bleed, right? And so that was often my interaction with the patient, is I would be in the trauma room and there'd come a moment where they'd roll the patient over and I would do so. That's great. It's a good thing to learn. It's an important skill. It's also a very odd way to have one relationship with a person, to have that one interaction with them. And in the book, I contrast that with a CU medical student, a terrific young woman who similarly saw a patient on trauma surgery, but then was able to follow them into the operating room, from the ER into the operating room, then onto the recovery floors, and then to see them in the outpatient setting. And to really get to see the arc of them as a person, rather than having that one really intimate encounter, right? And that's, I think, the difference that we want, is how can we create that structure where you can know a person a little bit more over time, always as a physician, always with the boundaries of that. I'm a psychiatrist, we love boundaries, but in a way that allows you to humanize them and see them more fully.
It sounds like you're saying that in the early 1900s, there were some medical educator reformers who came with a set of priorities and a set of ideas about what medicine might be and what community might mean. And that we're still living out, in a lot of ways, that model that has become ossified since then, and that it fails in a certain way to prepare students to be the kind of community-centered, longitudinal, kind of deeper engagement type of physician that you would hope for?
Yes. Long answer. Pandemics catalyze change. So if you think about the 30 years leading up to the H1N1 pandemic, there's all these forces that are pushing medicine away from an apprenticeship model to a professionalized research model. To be clear, there are some tremendous goods of that, and they're borne out over the next century. The buildings we're sitting in would not exist without the Flexner Report. Academic medical centers were so much smaller. They didn't really exist, right? This whole idea, all of this exists because of this vision of medicine. I believe we're in a second period where we're living through a pandemic catalyzing change. If you think about the period leading up to COVID, there was widespread burnout among healthcare workers, right? There was widespread frustration with how costly medical care was. There was frustration with how burdensome the regulatory environments were, for severe and persistent inequalities within medicine. And in the pandemic, I think of the response to the COVID pandemic as being this moment where you see the absolute best part of the Flexner Report, which is that people sequenced the genome for the COVID virus and within a year, there was an effective vaccine that we were putting in people's arms and trying to distribute. That's remarkable. That's the textbook of the body at its best. The failure of the textbook of the community is that we didn't do a good job of talking to people about that, right? And there was a moment in the pandemic where I think many of us thought, okay, the change this is going to catalyze is we're going to move towards racial justice, towards public health, towards investing in science again, right? And instead what we're seeing now is the other side of that pandemic, where we're saying, there's a group of people who are saying, the failure of this means we're going to defund this vision of medicine. And that's what we're living through. Like, if you think about all of what's going on politically today, it's really a walking back from this vision of the research university and the academic medical center. And it's shocking and transformative and kind of wild. And that's what pandemics do. They catalyze change.
So you think we can read this particular moment in part in light of what's happened in medicine and medical training and institutions?
I think we're still living in the COVID pandemic, right? I just think if you think about like H1, people talk about the Flexner Report as being what changed medicine. But then right after the Flexner Report, 10 years later, is H1N1 and World War I. And that's what makes people see on some level that you really need the kind of medicine that the Flexner Report was calling for. And I think what we're seeing now is a contested question about what kind of medicine our community needs and will support financially.
We've been talking a lot in terms of medical education reform, systems, big historical arcs, but you choose to tell this story about 7 actual students using their real names at the School of Medicine. Why did you do that?
Yeah, great question. Thanks so much for asking. So I wrote my first book. I've written several books, but my first book for a quote unquote general audience, I wrote retrospectively. And it was largely based on some clinical encounters I had with patients on the psych ward. I never published a book before, and you write things from memory. And when you go to a publisher, they tell you to change enough of their personal details that the person can't recognize themselves in the story. And that felt really weird to me because the personal details are what make us, right? And so I did that though, and then the book did better than I thought it would. So I set out to write a second book in that vein. And I realized as I was sitting with patients that I was starting to think about whether or not they'd make a good story. And I work on a locked-in patient psych unit, and there was no world where I could imagine consenting them, being like, hey, you want to be in my book? And that felt unethical to me. So I thought about who's a story that I could tell prospectively with engagement and full knowledge. So part of what I wanted to do was find a story about what works in medicine. And Dr. Adams convinced me that this was one. And so we literally, I could have published the book 3 years earlier, honestly, but there was a series of hiccups. One of them was that we wanted to spend a full year before the students even entered the curriculum when they applied to the Denver Health LIC to tell them we plan to write a book. So they knew even from the application process, hey, if you don't want to think about this, then once they got in, we gave them the choice all along the way. So there was more students originally in the book, and over time, students said, hey, this isn't something I want to do, which is entirely reasonable, right? That's what consent means. I let the students read what I wrote about them and let them correct things if they thought I got something wrong factually. I ultimately wrote everything and made the decisions, but I tried to engage the students multiple times through the process so that they could feel comfortable that the story represented them, at least one part of their life well.
And do you think that stories like this matter? We have a lot of inertia. We have a lot of inertia in our systems, in our institutions. Why tell a particular story about 7 particular students here in Colorado when it sounds like your concerns are so broad?
I think that's what stories are, right? Like, I think stories are what make people and how they shape these things. Medicine is ultimately a set of individual stories that ultimately add up into these larger narratives. It's kind of the way that both how I think of as somebody who likes to read, but also as a physician, I like to think about an individual person and their story. I didn't set out to think about these other broader questions that I had. I set out to tell the stories of the students. It's more that I think they're part of this particular historical moment, and so they wind up participating in these broader changes that are happening in medicine. I didn't set out to write a book about like, what do we do post-Flexner, right? That's not the story. The story was what's going on with these med students, and then I tried to narrate about how it's different than the Flexner model.
What do the students think about the book?
Yeah, great question. It's complicated, right? Some of them really liked having been in the book, and some of them didn't, right? It's complicated. To a person, I think they would say, I think you got some things right, and some things, I think about that in a different context. But that's fair, right? Like, it's their life, and I'm not telling the story of their life. I'm telling the story of their life during this clinical year. Does that make sense? But most of them really liked, I think, being a part of the process, and they were incredibly generous. And it was helpful to me to see somebody who was going through this process from the start, because you get used to your own world, right? Like I walk into a hospital every day and I'm comfortable doing so. Grateful to do so, but I'm comfortable doing so. And it's fun to see people who are like learning all the skills. So there's stories in there about like how they learn to scrub, and all the things like, and how to get dressed in the morning, how they pack a lunch, right? How they organize themselves in space and time while they're still learning it is more interesting than somebody who's in the middle of their career doing it.
We've talked a little bit about how the LIC curriculum prepares students to engage with the community. Do you think it changes the way that they engage with themselves, the difficulties they encounter in their work, changes their concept as clinicians?
Yeah, Dr. Adams and her team have run different versions of the LIC, and so many faculty have been involved in so many different ways. It has changed over time, but the way that we talked about it in the book and that fundamentally it's designed around is that students have some mentorship with some key faculty that they see patients with consistently. They have some people that they engage with to kind of round out their rotations, so they see much more like the Oslerian model for a small number of encounters. And then they get together weekly for didactics that are largely team-based. And that's a totally different way to work in a room instead of being in a lecture hall of 184 students, to say the 8 to 12 of us are gonna work and do problem solving together. And part of what I tried to write about in the book is the way the students cared for each other and got to know each other over time and shared their lives. Because you could see that they were living even as they were training, right? And that's one of the things that was super exciting to see is that Osler has this idea that you should just bracket off your life for 40 years and then sort of marry late in life and have a kid, maybe. And these students were really trying to live while they were doing it, and they did so together. I think that part of what we have lost today broadly is a sense of social togetherness. And part of what I like about the LIC was that it brings that back for the students and for the faculty.
Another thing that I'm thinking about, we've been talking about the process of writing, the purpose of writing. What do you think, one of the things that we're concerned with here in the center, in addition to bioethics, is integrating humanities and clinical care and humanities and research. And what do you think about the role of the humanities, the role of reading, the role of writing in everything that we're doing on a campus like this?
I tend to be critical of Osler, and yet people often quote Osler about why you should read. And one of the things that Osler says, there's this famous Osler quote where he talks about how to go out and practice medicine without books is like going out to sea without a map. And the thing is, Osler was a great reader. And I would say that one of the things we're suffering from in medicine today is a loss of reflective work and of narrative. And being able to engage other people, not just for a clinical encounter, but the question about how we change each other in that moment is the critical work of the humanities. Humanities isn't just about something that we add on to medical practice. It's an animating force with its own existential question, its own practices that we have to take seriously. And they'll change you. And I think one of the things we're missing so much is people not having a practice of reading, writing, or another art practice. I wish I was a painter or something. I think that you could do a lot of that work with that. For me, it's reading and writing. And so I try to practice what I preach. I try to spend some time reading and writing every day.
I want to make sure that we leave time for questions from the audience. I have one more question first before, so you can start to think and get, if you have questions ready for Dr. Nussbaum.
Then I'm going to ask questions of Dr. Kissler if you don't. We're going to hear about his own reading and writing.
Yeah, so think of lots of questions.
Yeah.
The subtitle of your book is 1 Year in the Future of Medicine. Are you hopeful about the future of medicine? And if so, what do you hope for the future of medicine?
Yeah, so think about what Dr. Adams and Dr. Zimmer and all the other medical educators on this campus have done, right? They've totally transformed the medical education model here in a 4-year period. I think the good news is that people broadly would say, US healthcare is not working. We have to figure out how to do it better, right? I always tell the med students that there's a cheesy psychiatrist joke. How many psychiatrists does it take to change a light bulb? One, but the light bulb has to want to change. And the good news today is that people want some change out of this system, right? So the question is, are you going to help drive that change? And I think the University of Colorado is trying to do that, right? And it's unusual for a med school to embrace this much change all at once, to change the preclinical and the clinical curriculum at the same time. But I think they did so because they thought the evidence was on it, and I think that they thought it was the right thing for their students and their community. So absolutely, I think that there is some reasons for hope.
Thank you. All right. Questions from the audience?
Professor Ryan.
Hello. So as you might know, I've been thinking a lot about aging health professionals, and especially the kinds of lessons and work that still remains to be learned, remains to be done as health professionals approach the other end of the career span. And as I'm thinking about these cohorts and cohorts of health professionals who have been trained in this Flexner model, when they reach the end of their careers, one might think they get the crown, they get the robe, or they get the armor. But in fact, what I've read is that at the end of the career for a health professional can often be very bleak. It can, hanging up your white coat is hard, isolation, loneliness, burnout, and you have it compounded by personal things like the role, becoming a caregiver to a family member or becoming sick yourself. There's a lot that's happening at the other side of the career. And I guess I wonder what your thoughts are on how the lessons that you see animating and even changing these young people might also be relevant to colleagues who are approaching or are retiring.
Professor Ryan, that sounds like your book.
Maybe.
You should write a book about that question, right? At the other end of the spectrum. Look, there's things that are really right about the Osler curriculum, right? And one of them is that it created an opportunity for wisdom figures. That as you grew older in medicine, there was a role for that older person within medicine. When I went to medical education, there was a group of faculty who'd been there a long time, taught a great deal, and just had this deep institutional and clinical knowledge. I think in many ways, the wisdom figure is the most endangered figure in medicine because so much of the work is based on clinical productivity, right? Or research dollars. Those are harder to do as you get older, just naturally. There comes a moment when you're like, I can't see as many patients as I could when I was 35, right? That's the challenge that people have. So the good news about Osler was that because of the way that it was structured, there was a model for that. So I don't want to be entirely critical of it. One way to think about what happened is that Osler, we kept using Osler's language to describe something that was really changing on the ground. If you look at what Johns Hopkins Hospital looked like in 1914 versus today, they're two very different environments. They both have the same name, but they really describe different social realities. So we have to think about what works on both sides. What works about the LIC, I don't think it's the only way to train people. I'm not that much of a stand for it. I do love it, but not that way. Is that it's social, it's problem-based, right? And people have relationships in it. So my guess would be that we need to think about how can we engage older healthcare workers based on their ability to be social, to work with other people, to solve problems that they alone can solve, right? What young people, the problems alone that they can solve is, man, they learn everything about where things are in a hospital. Nobody knows where like the snacks are better than a med student in any hospital setting, right? Old people, though, often know how those structures developed the way they are, what they've learned over time, which parts of the institutional levers to pull, right? And that's often a value that they can bring. And they need some social way to be in the hospital. So some of the physicians that I know are happiest are those who have remained on as like volunteer faculty or worked a certain number of days a week. And they work in a clinical setting where they can bring that environment. The flip side, some of the physicians I know who are the most happy are those who retired and then planned a totally different way of engaging in the world. There's a Denver Health doc who just retired, Josh Bloom. He's an addiction doctor, and he just retired. Great guy, lovely person. And I asked him what he was doing in his retirement, and he said, I'm going to sign up to learn to drive a big rig. You know, or we have a PICU doc who recently retired and is training to become a middle school math teacher. Right? So I think you either need to have one of the two. You need to have a wisdom figure role within medicine, or you need to find something very different to bring your skills and abilities to. But you should write that book, Dr. Ryan. Okay.
This is a question from the Zoom room. The LSE model sounds great. How does it fit in with mega health groups conveying medicine as opposed to solo provider? And if we lose solo providers, does that change the personal integrative aspect of medicine?
Yeah, great question. So I think I talked to you that the Osler model, there's a language that keeps being used even though the social realities changed. And Osler seems to be imagining, if you read him, two kinds of practitioners, either somebody who's at a university-based practice and or a solo practitioner. And both of those in various ways are endangered today. So I do think we need to find different language to describe the work of the fact that most healthcare workers are living in large systems and the question of what kind of agency and authority they have within those systems. Because I said that there's a decline of the wisdom figure. That's in part because large health systems don't need wisdom figures in the same way, right? That's not what they need. So I do think it does change those things.
I'm curious if you see some of the concrete drawbacks of the LIC curriculum might be, or challenges that it's meeting now that it's expanding and next time.
People like Dr. Adams and the med-ed leaders are the experts in that, but if you look in the literature that I've read, one of the questions is about how well it does for some subspecialties and how well it prepares people for that. I personally think, and I think Dr. Adams would agree with me about this, that one way to think about the LIC is that it's more like a liberal arts education in the sense that you are able to get a broad exposure and have a depth in a certain way that then prepares you to learn lots of things that you may have to then learn in residency. And the data that she's shown me shows that residents or med students who go through LIC are capable of doing so. But there may be a little bit of a different learning curve. I think the other thing is the question about whether or not it works in a clinical setting that doesn't have a dedicated group of faculty and a group of patients that have the whole range of pathology and needs that work. So part of what is helpful about something like Denver Health is that it's a captive medical group, right? So all of the physicians are employed by Denver Health. And so there's some ability to kind of engage them that's harder in a setting where the physicians are employed by lots of different groups and meet at the same hospital.
Well, yeah. What was your most unexpected challenge in writing this book, and what was your most unexpected reward?
Oh gosh, I love writing, but I'm not good at it. And so I have to edit constantly. But I think this particular project, it was really a challenge to write about somebody using their real name and to stay in relationship with them and get somebody else right. And I think it really pushed me to be a better writer because you want to say, look, can this person really see themselves in these words? Do I represent them well? What parts of their behavior do I want to pick out? But then also to write it as a story and to think about narrative and character and plot was really a learning process for me. Most medical writing doesn't have plot and character in the same way, and that's something you need for a good book. We have some people in the room who are looking at me with thoughtful faces, but I can't tell if they want to ask or if they're just polite, kind people. Please. Thank you so much for your long career in pediatrics and for coming today. I was not in med school here 40 years ago. I am old, but I'm not quite that old. I really think it is better, right? I can't tell you, every medical educator I meet here at every level of the curriculum is constantly asking themselves, and Andy and I know this, they're asking, what's the student experience and how to make it better? The student's really at the center of the med school here about how to make it better. I do think it's better. I had this occasion to talk recently yesterday with a friend of mine who I'd gone to med school with, and he's this amazing person. And he's amazing to me because from the very first day of med school, he knew exactly what he wanted to do. Like I had no clue what I wanted to do. And I remember meeting Joe and I was like, Joe, what are you gonna do with your life? And he's like, I wanna be an infectious disease doctor who studies HIV/AIDS among sex workers in rural northern China. And I was like, what? And Joe did exactly that. That's exactly what Joe did. And he always seemed to me to know what he was doing, why he was there, what it was about. And we talked yesterday, a couple days ago by Zoom, and we wound up talking about our first years of med school. And I struggled. I was not, it felt very weird to me. I thought Joe had done great. And what Joe said is, those were hard years and they didn't make sense to me. And it was surprising to me that even Joe felt that way. A guy who was that direct and that driven. And I do think that language of saying you're gonna set aside your life, you're gonna set aside your emotions in order to become this different person is a problem, right? Part of what I like about thinking about physicians as being like vampires is really more the idea of being a parent and a physician. I'm grateful I'm a physician, and I'm grateful to my med school for making me that. But the things that I loved about med school were often the stuff that wasn't the formal curriculum. It was the fact that I made friends along the way, that I learned some new skills. But often, a lot of the times in the lecture halls and the didactics were pretty miserable. My wife teases me. In a week, I'll be teaching the basic science course here on psychiatry. And my wife, who I met on the first day of med school, she says, this is your karma coming back at you because you were so reluctant to go to class when you were a first-year med student. You disliked med school so much, and now you're teaching it. And she says, life's funny that way. But I would say it's because I want med school to be different. And then, if I may, if you're interested in the question about where medical education is now, there's lots of great writing in the world. You could pick up something like Academic Medicine, any issue, and see that. But I'd especially recommend Lisa Rosenbaum's podcast with the New England Journal of Medicine called NOS. I think it's a fascinating listen about some of the questions that are going on in medical education. Thank you for coming and for your time. Please.
Hi, I'm Nina. I am not a physician. I'm a physical therapist, and I'm also a PhD student here now. And so I haven't read the book, but this is just making me think a lot about, as a physical therapist working in outpatient, you see people longitudinally. You see them, once a week. You may share care with a physical therapist assistant. This is going to depend on your setting, but you do have that privilege of developing a relationship with someone and seeing them over time. And then I'm thinking about, this clinical model of education and thinking about being a clinical instructor and having a student physical therapist in the clinic that's there for, 2 weeks or 12 weeks or 14 weeks. And you're slowly increasing the duration and the complexity of the patients that they spend time with your supervision, and you're discussing things with them. And I think, that developing a relationship with your patients is very important, but I'm curious from your experience in this clinical model of your work and as a physician, and from the perspective of like having that relationship being important, but also knowing that if you have a relationship with a person over time as a provider, that also then kind of muddles your view of how you see that person, and it can influence the time that you spend with them. And that's something that I always thought as a clinical instructor was challenging, when my student physical therapist is really bonding with this patient instead of really getting into, what is your clinical decision making? What's the best thing for them, and using those pillars of evidence-based practice, your personal expertise, and the patient preference, and how that can be skewed depending on the strength or the type of relationship you develop with your patient. And I'm just curious from your perspective of kind of what the clinical model, if you feel like you've noticed anything with that or had any thoughts on that.
Thank you so much. I really appreciate it. Thanks for being a physical therapist and a PhD student, and for teaching, and for having that continuity with your learners and with your patients. I think continuity is key. I think you get to know somebody very differently, both their body and their community, right? I talked about those two things. I'm a fan. And I think it's part of what works in the LIC. As a psychiatrist, we think a lot about alliances and boundaries. And we would say that the alliance is some combination of bond, task, and goal, and you can work each of them in different ways. This is one of the things I'm privileged to teach med students. The example that I'll use is that I'll tell people that it's a little bit like carbon, in the sense that something like a diamond, right, or a lump of coal has the same chemical structure and chemical formula, and the question then is how it's formed, right? How the bonds are designed is what designs them differently. So you can have different kinds of bonds in different times. Some of those bonds can color how you see someone in a way that's problematic. You can give them more time than the other student, than the other patient, when they don't need it, or when it causes harm to the other student or patient. Does that make sense? And so you have to be thoughtful about that. In psychiatry, we spend a lot of time training ourselves to think about how we have transference and countertransference with somebody, and to maintain those boundaries in the context of that alliance. So I talked to you about earlier about how I'm opposed to this idea of oscillary equanimity, but I'm also at the same time a fan of boundaries. So I'm really excited to see med students the next week. I look forward to all their questions. I'll engage them, but I'll also keep very firm boundaries in a certain way. My relationships with them will all be in that room. I'll try to engage all the students. I'll try to make sure that I'm hitting each one where they need to be engaged. Does that make sense? And I do similarly with patients. I try to think about when I'm spending too much time with another person, when I'm having countertransference to them, and kind of think through that. I'm imperfect, but I try to do those things. So, and then last but not least, Mark mentioned that I've written some other books. So I wrote a whole textbook called Prescribing Together, which is a reflection on the question about how you form therapeutic alliances while prescribing medications. I wrote that with a friend at Duke. So anyway, yeah, I love those kinds of questions. Thanks for asking them, and thanks for being an educator.
I think we have time for maybe one or two more. Emily, you have another?
We do have two on Zoom. The first one might actually be kind of short, so I'll start with that one. And it is, does the LIC model support or reject pass-fail grading for medical students in their first 2 years?
I think that's a neutral question. I think it can be done either way.
Okay. Second question. With the goal of producing ethical, compassionate physicians, can you comment on the relative influences of the students' individual personalities versus the medical curriculum that they are exposed to?
Oh, great question. There's all kinds of evidence that it's very hard to change people, and that the temperaments of people are pretty stable over time. You can change your personality and your temperament. Typically, the personality that most people want to change is to be more extroverted. There's ways to do that. But fundamentally, there's a group of people we're collecting. When Dr. Suhu does his work, for example, in the admissions office, there's a clear history of the certain kinds of personality and temperament traits that are selected by and large by medical education, and they predict what kind of specialty you go into. So you can administer personality tests to med students and see where they're going to go. I do think that one of the challenges is that we haven't historically always selected the right kinds of people to go to medical school, just on a very sort of equity basis, right? There's things beyond white guys who can do medical practice pretty clearly. But also those temperamental practices. My favorite book is, there's a book called Questioning the Pre-Medical Paradigm from about 20 years ago by Barr. And he showed that you could have people with more of a humanities or a liberal arts background, and they would do better in medical practice long-term. And that's one of my concerns about the Flexnerian model, is that it prioritizes people who can do really well in the MCAT and people who can do well in the research science classes. How transformative it would be if we said, hey, to apply to med school, you got to show that you can really write a beautiful essay, or you can paint something, or you can create a work of art in some other way, that you can have a reflective practice. And so I think it's a combination of both. I think we're not recruiting enough humanities people into medical practice, and then we're not asking them to do rigorous humanities work while they're here. Part of what I love about this center and the people in it is that they're saying, look, medical humanities isn't just an add-on to the work you're doing. It should be something that has rigor, just like the work in a biochemistry lab. I want to thank everybody for coming. I'm humbled that you chose to spend lunch with me, either online or in the room. And I thank my friend, Dr. Kissler, for doing it. And I'll tell you, someday I look forward to being on the opposite side of this when Mark publishes one of his books that he's working on. And he can tell you about his own work as a medical writer.
And again, it's Progress Notes, 1 year in the future of medicine with Dr. Nussbaum. Thanks so much.
Thanks for having me. Well, thanks for